What causes hip impingement?
Today we're going to show you the 3 most common diagnoses for groin pain with using these suits. We're going to cover hip impingement, adductor tendinopathy, and a sports hernia. Stay tuned to the very last one because it's the most complicated.
So let's start with adductor tendinopathy.
What does it feel like?
It feels like a tight inner thigh. So ultimately the adductor is a muscle that comes from the pubic bone area, runs down the inner thigh, comes past the knee joint, and attaches right at that upper inner shin there. And so really anywhere along that chain you can feel tightness, you can feel a pulling sensation. It can be kind of local, especially if we're talking tendinopathy. The tendon is where it attaches to bone. So usually you're gonna maybe feel some pain located at where the tendon is, kind of local to the pubic bone or maybe even somewhere down in the knee.
Yeah, I don't feel like I can really push this hip down, or it feels like it pulls it there. It feels like it just won't let go.
Like a tight muscle. Yeah, absolutely.
So who gets this type of thing?
I see people more in the athletic population dealing with some of this. Some of our soccer players, a lot of hockey players as well. Anybody who's kind of challenging more lateral movements because that muscle is involved in stabilizing you in some of those motions, that's what I typically see.
Okay. I know that when I've done something like a Copenhagen, so I guess this is like a floor Copenhagen, and so this is the one that hurts, right? Just doing something like this kind of hurts it, like it hurts right up into there.
Yeah, absolutely. So if you are starting to maybe build some exercises in that challenge that muscle, and we went a little too quickly and push that threshold, you might start to feel it with some exercises that challenge it too.
Okay.
So it can be really, really hard sometimes to differentiate this from other things that we're going to be discussing in the video. So you guys will see a little overlap with some of this. But usually what I want to start with is what we would call passive range of motion. So the adductor muscle is responsible for kind of bringing the leg inward here. All right. And so we might actually see some lack of range of motion when we stretch through this outward motion, kind of pulling it away from the body towards the lateral side of the body here. It might not go as far. It might create some pain and discomfort when we're challenging the stretch of that muscle and of that tendon. You may actually also notice some tenderness to palpation, so not necessarily in the belly of the muscle itself. Let's have you bend here. So not here in the belly of the muscle. If the tendon is involved, you're gonna feel it where it attaches to the pubic bone. So usually in office, I'll have people kind of locate their pubic bone, and then over their fingers, we're gonna do a little palpation right where it attaches to the pubic bone to see if there's a difference from side to side or if it recreates some of their discomfort as well.
What about like resistance testing then?
Resistance testing too. So here, don't let me pull you outward, seeing if that kind of recreates some discomfort. If it's acutely injured as well, you might even see just a little bit of weakness with that, but nothing too concerning. Weakness may come maybe from the pain stopping you from trying as hard as you can with that. But resistance testing is a part of this as well.
So how do you solve this one?
Ways to solve this one would be things we can do in office, like some manual therapy to the area to just get rid of some inflammation. But ultimately, tendons love to be loaded, and finding a threshold that they can tolerate well. So isometrics of that muscle, of that tendon, is a great way to start. Finding a nice little kind of beginner's intro into that, and then progressing over time as it begins to feel a little bit better. So something like we mentioned before, a Copenhagen, maybe a modified version of a Copenhagen is a really good way to introduce yourself into loading that tendon and starting to see some healing there. So now we're on to hip impingement.
Now we're going to cover hip impingement. So Dawn changed to her bone suit since it is a bone condition.
So what does this usually feel like?
It usually feels like groin pain because we're doing a whole video on groin pain.
Yep.
So unfortunately, all these are going to feel like it's groin pain, but I did see some great references where they say people have a classic C sign. Put your hand on your hip and make a C. It's the C sign. So when people have the little thing, and I wouldn't say it's 100% indicative of it, and usually it's unilateral, but it could be both. But I would say most people classically have one single side. The other one is less common, but it does happen. They also feel stuff in the back side of the hip a little bit, if you want to turn around. So right into the SI joint here, a little bit into the butt cheek a little bit down to the thigh, but usually like right there, you see how where Dawn had her surgery? Yeah, so that's where the compaction's going to be, because it's a compressive condition.
And who typically gets this?
I see between usually 20 to 40-year-olds. Usually they're men. It can be women as well. But it seems like they're athletic individuals, and they tend to do deep ranges of movement, like squatting, a lot of twisting, a lot of kicking, and things like that. But I have seen a lot of people doing weightlifting, doing too much range for their body type, and they end up having more compaction with it.
So what exactly is hip impingement?
So if you turn towards me a little bit here, so we can actually see, turn towards the camera a little bit more. So this is a great model for it because this is called the innominate bone. Here's the femur or the thigh bone. You see that circle right there? It's unfortunate this model didn't have like differences, but this is kind of like a golf ball. But with someone who has a cam deformity, it becomes an egg. And so it's more like oblong in shape. And when you flex an egg, it has different compaction points. Or there's a pincer type, which is a growth off of here, which creates more compression as a normal femur comes up, or you can have a mix of both. But there's usually some bony aspect, but I've noticed that people, if they talk about the bony aspect with them, they say, well, why would this change? My bones aren't gonna change, and this needs surgery. There's actually a mechanical aspect, which we can show on some of the exam here, to show how we would reduce it with things like corrective exercise.
Yeah, you're not going to necessarily change bony growth, but you can change the way your body perceives that or how painful it is. So how do I know if this is what's going on? How do I test it?
Well, go on your back. We'll do some testing and then scooch this way a little bit. Okay, so I'm going to show on this hip with her. And so normally the things that will help the most is going to be passive versus active range of motion. So the hard thing to decipher is people say, oh, I bring my knee towards my chest here and it hurts. Well, but your hip flexor's doing work too. So how do we know it's not that? So usually doing active range of motion here, where she does the movement, we can decipher is that painful or not. So that's number one. And that would be more with a hip flexor condition as well, but it could be with hip impingement. And then also we can do passive range of motion. So I'm doing the work. So I noticed that in the exam sometimes people help, so relax. Okay, so you can see she could have had a false positive because she was very helpful. You're so helpful. And then so I'm going to move her hip up that way and a little bit across her body. And I'm going to turn it a little bit, which this is called Feder's test. You can also do Scour's test, which is scouring parts of the acetabulum, looking for that little pincer part. And we can see if any of that bothers her. But generally, if this is negative and the exam's done really well, then this is not hip impingement. But it can still be other things that are creating groin pain too.
I would say everybody has some range that you'll take them through that's going to be a little bit uncomfortable. But usually we're looking for like range of motion deficit too, differences from side to side. It's like, you know, we're getting it fairly soon rather than I'm feeling pain when I'm all the way up here, right? There's ways that you can kind of differentiate the normal versus abnormal.
Yeah, and we can also do something called a dynamic test too. And so earlier we mentioned how mechanics how the active tissues in the core and the pelvic position actually matter. So let's just say Dawn had positive, like that doesn't feel good. And if you do a little partial sit up, and then all of a sudden she's like, oh, that went away. And I could even push a little bit more. What she's doing is she's making it so her pelvis is posteriorly tilting. And so she's taking the pressure off of the rim just by changing her mechanics. So an anterior tilt plus lumbar extension is usually a big mechanical factor associated to this. And part of the rehab is to change the dominance that you are doing that in, or just change the support of your core, the strength of the glute, the strength of the leg, and those can help a lot.
Yeah, absolutely.
So Dawn, do you see any people with conditions like this, and like, is there anything else that they tend to talk about?
Yeah, I think usually it's more the concern of like, we found this thing on x-ray, so like, how are we going to change it? And we kind of mentioned that already. It's the mechanics that got you here. So, you know, we can kind of reverse engineer those mechanics to make things feel better overall. We can get you back to what you want to. Ultimately, it's just kind of dependent upon what the goals are ultimately and how painful this is.
Yep.
Now onto sports hernia. So sports hernia can be tricky because there is a lot of the location to some of the areas that we're talking about. They all can kind of feel pretty similar. So if you do feel like you're having a hard time diagnosing this, you can reach out to us. We do telehealth, and so we can help take you through an assessment, figure out what's going on. We also have an ebook that you can, I think it might pop up or it's in the link below. Click on that and it'll help take you through some more detailed things.
Yeah, you'll even find a lot of crossover too in some of the chapters we have in the book about resisted testing and so on, which we'll show in this here today, but it hurts with both. So it's really hard to know, but there's other discerning factors too.
Yeah, absolutely.
So what does it feel like?
What I've seen is people will typically have tenderness at the pubic bone, okay? It can kind of refer upwards, so they'll feel it into the lower abdomen there. Because ultimately in a sports hernia, there might be one or multiple tendons involved or structures involved. So the rectus abdominis, where it attaches to the pubic bone there, so we can feel some of the discomfort into that area. You can feel sharp pain into the pubic bone. It might radiate into the inner thigh as well too. And over time, maybe some compensating factors, it might even kind of radiate outward over the iliac crest there.
I've even met some people who end up having testicular tightness with it, which is a little bit different than the adductor tendinopathies.
Yeah, usually if the testicle is involved, there's no swelling, there's no redness, there's none of that going on. It's just a feeling of tightness into that area.
So who gets this type of thing?
We usually see more in the athletic population, soccer players, again, hockey players can get this too, some track athletes. Usually it has to do with lack of abduction or extension. When they lack that there, then they might get it through the spine. So all that extra pulling on those front structures there will cause some aggravation to those muscles.
Yeah, it's kind of like the kicking and the extending together, right?
Absolutely. Yep. Usually anybody kind of going through that motion, you can see this in the strength training population as well, but if you're just out going for a walk and you start to feel it, that's probably not what's going on with you.
So let's do some tests then, maybe to identify at least the most common tests that we use.
Sure, lay on your back for me. So I usually start with just a little sit-up test because a lot of times people in this population cannot tolerate core exercises in the very beginning. So what I usually do is have you drop your legs, find your pubic bone for me. I'm gonna come on top of your hands there, and we're gonna kind of look for some firing of the muscles. So I'm gonna have you do a small little crunch and then back down. We're gonna see if that hurts. We're gonna see if it reproduces their pain. And then what I'm looking for under my fingers is if there's one that fires before the other. The one that's delayed is probably the one that's injured.
Other ones that I've seen too is there's like a resisted hip flexion and sit-up test. So even doing something like this, like self-test, like with telehealth, this tends to work out really well.
Yeah.
Or putting like a ball between their feet and making them squeeze, like they don't like that.
Yeah.
I'd say it's like 75% of people don't like either of them. But that would probably bother an adductor tendinopathy too, right?
Yeah, absolutely.
So how do we resolve something like this?
Usually the way we resolve it is by getting muscles that support and around the area to work better, because usually these are muscles that aren't already weak in the beginning. They're fairly strong, they're overworking, and we need to build better team players. So things that kind of get you stronger in the lateral side or in the back side can be really helpful for this. And there are some mobility things that we'll see that are lacking and usually in this population of people, like hip extension, hip internal rotation. We want to restore your ability to access that range too long term so that this doesn't occur.
Surprisingly, I think I've found that like people have mid-back stiffness as well with this thing too. Wondering what's next? We have videos up in the corner here which are completely related to this video. And down at the bottom in the link description, we have all of our links for our free books and webinars associated to more details about this topic. Take care.